Okay, you are live now. You can start if you want.
Hi, my name is Lavelle Romaine, and I'm one of the clinical recruiters here at City of Hope. We want to welcome you to the first Nurses for Hope panel discussion. We'll be having live panel discussions the fourth Tuesday of every month at 3 o'clock in the afternoon Pacific Standard Time. The live panel discussions are available on Google Hangout. It's on air, and it's going to be about topics that are relevant to nurses. Our speakers will include City of Hope nurses, hiring managers, and nurse recruiters. You can engage with us through a tweet chat on Twitter, as well as a Q&A session on Google+. Our live sessions will also be available through YouTube after the session is over. Before we start our discussion, if you're watching on Google+, you can submit your questions through a Q&A app. If you're viewing the broadcast through YouTube, the annotations are available on the video. The annotations will point you to the Hangout Air on page in the Q&A app. Joining our discussion on Twitter, make sure to add hashtag Nurses for Hope to your tweets and to your questions. I'd like to introduce our panel of experts. These are the professional practice leaders here at City of Hope. We have Chemo, Jennifer Peterson, and Marie Malinek, as well as our other clinical recruiters, Teresa McCormick and Leilani Patatzel. Today we'll be discussing oncology nursing and how to break through oncology nursing. So our first discussion topic will be how working at City of Hope is different from working in an oncology unit in an acute care hospital. So I'll open that up to the three of you. And how do you feel nursing at City of Hope differs from oncology or med-surg nursing at a community-based hospital?
Well, I think, first of all, we have a bone marrow transplant unit. I think that in and of itself is very different. Not only do we have a bone marrow transplant unit, but the types of transplants that we do. So not only do we do auto transplants, we do allogeneic transplants, and then we have more recently CAR T-cell therapy. And so just things like that, as well as clinical trials, we have that I think is unique to a research facility. And then we have newer functions such as the day hospital where we do outpatient transplants for multiple myeloma. So I think that makes us very different than just the community hospitals.
For someone that doesn't know what T cells are, can you explain what that is?
So these are the memory T lymphocytes that have been modified and expanded to be produced in volume, and they are programmed to recognize tumor cells. So it's basically using the patient's own immune system and boosting it up to recognize the cancer cells.
So it's ramping up the patient's immune system to really help the body attack the cancer cells that it hasn't recognized as foreign initially. So I think those are some of the complex therapies that we can offer our patients that may not be available to them in the community setting or other acute care hospitals. A lot of research goes on at City of Hope, so it's nice to be able to translate that from bench to bedside as far as offering therapies that have been either developed or trialed at City of Hope and making those a reality for patients that may not have other options in standard of care for oncology.
What would bench to bedside look like for somebody that was participating in that?
So I think one of the many trials that has occurred recently at City of Hope would be the blinatumomab trial, which was trialed with an ALL or an acute lymphocytic leukemia patient population who had failed multiple other therapies and didn't have a lot of other options for therapies. So this was something that was trialed. One of the sites for trial was City of Hope, and it was a drug that was very quickly accelerated through the FDA and approved for this indication of acute lymphocytic leukemia in an adult population. So it's very exciting to see something that may either be referred to as a number or may not have a drug name yet, and then have it become commercially available because of the success in the trials and the patients who had good outcomes.
So being part of research would be different at City of Hope from other acute care hospitals, as well as the complexity of our patients. Anything else?
I think the relationships that the nurses develop with the patients, because our patients are here for such therapies, that their length of stay tends to be a little bit longer. So we get to know them over a period of sometimes months, as opposed to just the days that a community hospital might have a patient in-house for. So the relationships that develop sometimes last for years, decades. They come back and see us all the time.
That's great.
Yeah.
That's great. I know we have a bone marrow transplant reunion
Right.
every year. Can you tell us a little bit about that?
I think that's one of the very encouraging highlights of the year, for especially for staff, to see patients who come back, patients who may have been treated years ago. Patients always remember their nurses, and it's very fun to see the patients who have had successful transplants and are doing very well. They're back to living their lives, and but they have such great appreciation for the care they received and the nurses that they got to know throughout their transplant. So it's a great opportunity for patients to come back to campus and the staff to reunite with them and their families as well.
I also think it's a great inspiration for the current patients who are undergoing therapy. You have a lot of patients that come in from the clinics that go to that reunion and they get encouraged. But also you'll see it from Helford, where we have glass windows from the 6th and 5th floors, where they're not well enough to be outside because they're still neutropenic, but they will watch from the windows and be inspired. And they'll actually say, you know, like, next year that'll be me. So.
I have noticed that they have at times united the person that gave the transplant with the person that received it.
Right.
Can you tell us a little bit about how that happens?
I'm not sure how it happens. I know that they arrange for the donors to meet the recipient, and it's probably one of the bigger highlights of the picnic. I would imagine that our donor.
So it's arranged through the matched unrelated donor program, so that the patient and the patient and the donor have to agree that they both want to meet one another, and then the arrangements are made, and the actual meeting occurs on the morning of the bone marrow transplant reunion. So the physician introduces the patient to their donor. It's a surprise. They've never met before. They are able to communicate anonymously prior to their meeting, but they haven't met before. And I think it's a very emotional, even for the patient and the donor, it's extremely emotional because the patient feels very grateful toward the donor for the donation that they've provided in order for this patient to overcome their disease. But I think also as a spectator, it's very emotional to see these two people meet in person and the appreciation they have for each other, and oftentimes the motivation that the donors have had in becoming a donor or enlisting on the registry for donating cells.
And I also think for the nurses, it's a lot of inspiration too, because especially for the inpatient nurses, you see the patients when they're at their sickest. When even if they have not been readmitted, they're not well enough to the point where they're at that state yet. And for the patients that are readmitted, they're readmitted because they're sick. So a lot of times when you're in the midst of all of it, it's hard for an inpatient nurse to sort of see the value of it. And then you have things like this that really remind you why you do the things that you do.
That's great.
Yeah.
Thank you. Can you talk a little bit about, we have a new nurse residency program as well as an RN training program for experienced nurses. Can the three of you highlight of what it would look like to be part of the new grad training program? And then also if you were an experienced nurse that was interested in oncology and wanted to participate in that program, what would that look like? What does your training involve in doing that?
So our new nurse, new resident program, it's a 16-week program. It consists of 10 didactic days. So the 10 days are broken out into weeks. So essentially it's 10 or so weeks. And during those 10 weeks, you have 2 clinical shifts with a preceptor. And then at the end of those 10 weeks, we then launch you onto unit with 3 full shifts, which is what a full-time nurse works. And you're still under the guidance of a preceptor. We put you through a 2-day transplant class that's for all hires that go through the program. And then we put you through a chemo bio class so that you get a provider card to administer chemotherapy. As well, we have a cancer basics that we put new grads through.
Excellent.
So we like to provide a strong foundation for understanding the disease processes and why we provide the care that we provide to this patient population. So I know a lot of nursing programs do very little content in oncology, so it's very challenging for someone who doesn't have any nursing experience to come into such a complex patient population. So a lot of our didactic days we utilize to provide information on disease processes, why we care for patients the way we do, why we provide the care and the support that we do, why it's important, as well as practicing some skills. So to provide some opportunities to practice skills prior to being truly in the clinical setting and having the patient watching, or the patient and the patient's family member watching you as your hands shake and you do something for the first time. So I think it's nice to have that opportunity where it's a non-threatening environment. The professional practice leaders provide a lot of support and coordinate this program so that we can ensure people have a strong foundation to provide professional and competent care and are able to understand and also give that information to patients and patient education of why the care is important, why self-care is important for the patient and the needs they may have in transitioning from acute care to home.
And for our experienced nurses that want to come to the City of Hope but have not experienced any oncology, we, especially in the ICU, what we do is we allow them, we have them orient to all the different floors so that they have a nice overview of what the transplant patient population is, the patients that are receiving chemo. Even our pediatric unit is shown to them, and they actually do a stint of anywhere from 3 shifts or 6 shifts depending on their needs. We send them down to PACU. So we try to give them a complete overview of the facility before they come into the ICU, because again, because of the nature of our patient and their issues, it's a totally different feel to it than a community hospital would be.
Even in the ICU and in the pediatric unit.
Yes, yes, yeah, it's a little, it's special.
How would you say an ICU at City of Hope differs from an ICU in a community-based hospital?
In a community-based hospital, you find a lot of the issues are separated out. So you have a cardiovascular. If it's a large enough facility, you'll have different ICUs for cardiovascular, maybe for surgical trauma, just different areas of medical ICUs. So in the ICU at the City of Hope, because we cover all the patient populations, we are responsible for not only knowing the surgical aspect, but also the medical aspect of critical care. And then we are also the only ICU at City of Hope, so we also cover the pediatric population. So we have to be trained in the care of the pediatric intensive care unit. We're very fortunate. We have intensivists in-house that stay with us. We also have respiratory therapists that live in the intensive care unit. So we're very well supported. It's a little, it can be a little off of a different point of view for a nurse that has come in from the community setting to come into our ICU, because again, the issues that the patient faces are usually based in either in treatment or in the disease process itself. So you have to know that part also. Yeah. So
It's multi-system care versus individual system,
Right.
dependent on the problem. I think as well with the experienced nurses, we try to provide those nurses with a good foundation, realizing that they do have experience in another specialty, but helping them to understand the qualities that it takes to care for an oncology patient and the items that maybe aren't important in other patient populations, but are extremely important in the oncology population, particularly infection control. So our patients are very immunocompromised. It puts them at very high risk for infection. And I think when nurses come from outside facilities, they're a little surprised at how fastidious we are with our hand hygiene and providing the best infection control, vascular access device care to our patient population to try to avoid infections the best we can.
Right. And Kay kind of touched on what the new nurse residency or the new grad program, what that entails. What about the experienced RN training program? How many weeks is that for someone that wanted to get into oncology nursing here at City of Hope? How many weeks is it? Similar to what Kay mentioned about the didactic portion plus the on the floor?
Really similar. What we've done in the past is we've utilized some of the content from the resident program because it's very helpful for the non-oncology experienced nurse to understand the disease processes and the care that we provide to our patients, they're usually on a little faster track than the new residents are, because they really have their confidence in their practice. They just need to learn our policies and procedures for patient care, as well as the disease processes and the administering the therapies and the supportive care that we provide to our patient population. So it's variable. I say we do things on an or we evaluate on an individual basis for nurses. Some nurses acclimate very quickly and may have some other experience that translates a bit. So solid organ transplant utilizes some similar immunosuppression that we do in our bone marrow transplant patient population. So they may be familiar with some of the medications we give. So we evaluate them individually and make sure that they're comfortable with the care, their knowledge base is adequate, and they're ready to launch onto independent care.
What type of a nurse coming from an acute care setting, what type of nurse would do well at City of Hope in the training program for experienced nurses? What are we looking for? What types of qualities? What have you seen as the characteristics of a successful nurse here at City of Hope?
Intellectual curiosity.
Yes, one of our values.
One of our values
Yeah.
really speaks to the nurse that does well. We do not only a lot of things that are so different from what you see in the community. You have to have that drive to find out, why are they doing it? What caused it? How does it affect the patient's care and outcomes? So you have to be a self-learner, a lifelong learner.
Self-motivated.
And self-motivated. And the resources are there. I mean, we have phenomenal resources for the institution. I mean, the ability of the access to the library, our nursing research facilities. I mean, there's so much there. Lectures, luncheons. I mean, you name it. It's a constant flow of information that goes on in discussion, and you can be as much of a part of that as you can of patient care. You just have to be willing to put yourself out there and attend these things.
And I think intellectual curiosity is
Yeah.
a big thing, because it is a very steep learning curve,
Yes.
even for an experienced nurse. So the thing with an experienced nurse is that there's a duality to it. They are more likely to be resilient to criticism, what have you, because they have past experience to draw from and they have confidence in those experiences. But then also they more tend to feel inadequate because they have a realistic appraisal of how they should be progressing. And I think people need to realize that even as experienced nurses, you're coming into a new area that has a very steep learning curve, especially in an area like transplant, that you will be starting pretty much from the ground. So
You have to be flexible. You have to be open to learning new things and maybe new ways of doing things. So if you've learned one method or one way to perform a skill, there may be a different way to do it based on our patient population. So really having an open mind, being willing to learn that another right way to do something that you may have learned in your previous experience, as well as being really motivated to learn new things, take some feedback from people who have experience in the field, and cut yourself some slack, because it is a very steep learning curve. So you have to give yourself some slack in the fact that you leave a job usually where you're very comfortable, and it's hard to be the new person again, but you have to realize that you'll get there. It's just adding more tools to your tool belt and more skills to your skill set.
It's the return to the novice. So you come from an advanced nurse or an expert nurse, and all of a sudden you're in an arena where you thought your nursing was going to be able to cover you, carry you through.
Right.
And unfortunately now there's a piece to it that you've never heard of, or maybe it's brand new to you, or you've known it in a community-based way, and all of a sudden it's been pumped up a little bit. So it can be a little disheartening. We have to make sure we support them well, and we do. We tell them, it'll all come. It'll all start to make sense. It's
You
just
have to be patient.
you just have to be patient. Yeah.
You mentioned intellectual curiosity for the experienced nurse. What about that new grad that is coming in? What do you feel makes the best or the most compatible new grad here at City of Hope? What the characteristics that you feel that would be crucial for the new grad coming in to City of Hope?
I feel like it's largely the same too. Intellectual curiosity. I mean, you're coming straight from nursing school. They tell you what normal vital signs are, what normal labs are, and then you come into a bone marrow transplant unit, and
The new normal.
yeah, the new normal is abnormal. And then you have, so one of our previous hires were saying that a patient's white count was 0.1, and nobody in the room was freaking out. Like everyone was calm.
No one was alarmed by this except her.
Yeah. So, I mean, that's something that we induce the patient into neutropenia for a specific reason.
Right.
And so I think there's a learning curve with that, and you really have to take the initiative to learn the disease, to learn the therapies. And I think that will help a lot.
You have to be willing to do a little bit of work on your own.
Okay.
So I think that's one of the qualities that we look for is somebody who's willing to not say, now that school's over, I am done. I'm not going to read anymore. I'm not going to look things up. I'm full. I'm done. I know it. This is all I can learn. Because I think even as experienced nurses, we learn new things every day because things change, practice changes, we find out better ways, or we go back to ways that we didn't think were as adequate. So I think being very motivated to continue to learn, be a lifelong learner, because there is a lot to learn and it's constantly a changing practice.
That's great. I've actually heard that we have homework in our new grad program that you can come back after the didactic every week, and there's some homework. Some have said it's identical to being in nursing school. Can you elaborate a little bit about that?
So we have a running case study, or we have multiple running case studies that we give to the new grads to work on. Essentially, it's the same patient. They just take on different patient scenarios based on the didactic for the week. And so it's really to help facilitate their thought process. So the purpose of us as facilitators, we're not to disseminate information, but more to guide the discussion. So you think it was this, but if it wasn't, what are your other alternatives? What should you be suspecting? And I think from the last cohort, they've mentioned that it's really been invaluable because it really helps to trigger those critical thinking skills.
It actually develops critical thinking pathways because that's not a skill that we are all born with. It is something that is developed. And so the questions drive that thought process because it's never the first thing you see. It's always a something else is playing into it. And again, because of the complexity of our patient population, that there's something else is driving what you are physically witnessing. And you have to be able to understand that and put that together. And that's a difficult skill. It's a very, I always tell the new grads that no one is born knowing how to be a nurse. It is an acquirement of patience. It's a knowledge, continually looking things up, continually talking to other people,
Asking the right
asking questions, looking at labs, chest x-rays, and learning how to put it all together. Do they do it all the first week that they're there? No, no, not even close. It's a process, but we give them time to develop that process and time to develop into a phenomenal bedside nurse. We really do. So.
Great.
Yeah.
So it sounds like intellectual curiosity and critical thinking skills are very, very important for this program.
Well, and I think some of the scenarios that we've utilized help the staff recognize what they're seeing on the unit. So in those clinical shifts, it translates over to, oh, now I know what this medication is for because we looked it up for our problem-based learning scenario. Or now I understand why we're providing this care to this patient because it was in our problem-based learning scenario. We also help guide them towards some of our policies and procedures frequently used and will be used over and over again so that they're familiar with locating those as well as the content of those and helping to guide their practice.
That's great. The other questions is, what are some of the challenges that you see in oncology nursing? What are some of the things that the nurses at City of Hope face as an oncology nurse in our situation?
I think with the transplant patients, number one is how acutely sick they are. But also when they're not sick or when they're not seemingly sick, I think that it's really important that nurses are very aware of the fact that your patient may look okay, but they're not your community hospital patients and that they could crash at any moment or because of the therapies that we're giving them or because of their disease process. And so I think it's a lot of it is recognizing what is their abnormal baseline, but then what is truly abnormal for
Right.
them.
For them,
Yeah.
individual.
I think too, we treat a wide range of patients from young adults to older adults, and really recognizing how the disease has impacted the patient and their lifestyle and what they were currently doing in their life when they were diagnosed. So I think also one of the challenges may be end-of-life care. So providing end-of-life care, we have a wonderful supportive care department that helps to assist with providing end-of-life care. But I think another piece of nursing school that is very small in the grand scheme of the education is, how do you provide end-of-life care, and how, as a nurse, are you comfortable providing that end-of-life care and support to the family members, friends, whoever are involved in the patient's care. So I think it's one of the questions that we often utilize in interviewing candidates, because we need to know, and they need to know, that this is a part of our role as nurses in oncology, is providing end-of-life care, and really sometimes a good death is a good outcome for a patient. So realizing that that's a possibility and that may be a skill that's required.
What are some of the things that enable that skill to be manifested for a nurse here at City of Hope? What are some of the skills that would help a nurse be able to come alongside of a family during end-of-life care?
It's the power of presence. I think you have to recognize that some situations don't necessarily call for words. They just call for you to be present with them. I think the empathy that a nurse exudes
Right.
is extremely important. Patience goes into a lot of this. The ability to recognize distress signals when sometimes they're not as overt as you think they could possibly be. So these are not things that you learn overnight. And we have a wonderful supportive care medicine that you were talking about. We also have social workers, all types, chaplains, all types of other people that are there. They do a wonderful job of just supporting the staff themselves. When there is a period of time that goes by, they actually have tea time for the soul on different units, where the pastors come in, and it's a time to share or not share, or if maybe the unit has had a particularly difficult time for multiple reasons, the manager will call for a tea time for the soul, and it gives the staff not only time to kind of de-escalate, but also to bond together as a unit, because again, that's another very important thing, is to feel the sisterhood, brotherhood with your fellow nurses, that this is what we do together. You know, I remember when I was at bedside, one of the questions that was always asked was, how can you do that? And I'm thinking, well, how can I not do this? Someone has to take care of these people.
Right.
And it's not just the patient, but it's the entire family that you take care of. Yeah.
And I think that's the beauty of nursing. There are a lot of opportunities and varieties in nursing, and oncology care isn't for everyone, but the people who find that as their niche, they really learn how to interact and provide this multidimensional care for patients as well as their family members.
So it's holistic nursing, look at the whole person. Okay. Can you talk a little bit about clinical trials and research that goes on here at City of Hope, and what would be the responsibilities of a nurse that was caring for a patient was part of clinical trials and research?
So I think with clinical trials, they're very structured. It's a protocol. There's a special way of reading orders. The orders are very intricate. I think it's that attention to detail, knowing where your resources are. So we have clinical nurse researchers, and we have special, pharmacies. But it's also being able, so again, that intellectual curiosity, looking at that protocol, reading about it. And I think one of the great things about working at City of Hope is that when you take care of these patients, you pull up the protocols, and this is like potentially everything about this drug that the world does not yet know. So I think that is a very insightful experience, and it's a very, it's really part of what makes working at City of Hope really great.
It's exciting to be able to offer treatments or potential treatments to patients who may not have had other treatment options. Like Kay said, having very high attention to detail because of the way the protocols are written and the requirements of a protocol in order to stay within the regulations of that protocol. So really being aware of what your responsibilities are, what you need to do, what medications cannot be given when the patient's on that trial or that particular protocol, so that it is the biggest thing I think is the attention to detail and being aware of the impact you can have on this patient if this trial goes well, and for the institution regarding the trial results.
It's an enormous sense of pride, I think, for the staff to be part of what is going on in medicine, and how we are, you hear these, some of the talks that are given, and it's amazing. We went to a talk the other night about the opening up of what they call the Alpha Clinic, and the amazing minds that are working a lot, and the nurses are part of this, that are offering all treatments, novel treatments that are just now coming to the front of treatment of some of the diseases that we have out there, not just cancer, but of course HIV. It's amazing. It truly is. And it's a huge source of pride to say, oh yeah. And I've had people come up to me and they find out, you work at the City of Hope. I've heard of the City of Hope. They discovered, the human insulin there. And I mean, it's amazing. Well, we didn't really discover the insulin. We discovered the process that makes the insulin, but it goes along with it.
Yeah.
Helped a lot of people.
Yeah. I say the same thing. Yeah. Very, very true.
Yeah.
Very true. Before we get into some questions that some people have asked online, we just wanted to talk a little bit more about City of Hope. That City of Hope is over 100 years old, that we're located in Southern California in Duarte. And as we talked previously, there's been several breakthrough cancer drugs that were pioneered here at City of Hope. And a lot of the human insulin was pioneered here too, which makes it awesome. They're not only working with cancer patients, you're also working with diabetes and the research that we're doing with that. We hire experienced and new grad RNs for oncology, bone marrow transplant, ICU, and pediatrics. And also we'll be having a new RN training program that will start in August, and we'll be accepting applications from April 1st to the 30th for that program. And then we'll also have an experienced RN training program that will start in August also. City of Hope is one of 41 NCI designated cancer centers. And we've actually done more than 12,000 bone marrow and stem cell transplants. So it's a pretty neat place to work. Also regarding robotics, City of Hope is one of the first cancer centers in the country to adopt robotic prostate cancer in 2003. So just wanted to give you a little bit of information about City of Hope before we answer some of the questions that have come in online. First question is from Diana D. that was asked on Google+. Asking, would we consider hiring RNs that currently have an associate degree in nursing but are en route to completing their BSN within 1 year? And because we're going for magnet status, we are requiring that the BSN diploma is completed. And once you complete that BSN, would be more than happy to look at your application. So that's a great question, Diana. The next one is from John. And in what way can being an RN in oncology be stressful? And I'll let you guys answer that question. Great question, John.
Just the medications.
Medications.
Just the medications.
Okay.
Because as we all know, we don't give a medication if we don't know what it is and how it's going to affect the patient and the patient's situation. So the amount of medications can be quite overwhelming,
Okay.
Especially in our transplant population.
The complexity of the patient care.
Yeah, the constant.
So I think oftentimes it's not single organ, it can be a multi-organ
Right.
effect of either the treatment or the disease. So the acuity can be extremely high. It can be a very complex patient population to care for. And I think you really have to be on your game. So you
Yeah.
have to be aware, your assessment skills have to be very well tuned in order to early identify issues that are going on with the patient and be able to notify care providers so that we can intervene early.
Mm-hmm.
So I think the complexity of the patient population can make nursing a bit stressful, but I think to the advantage of the staff are very supportive of one another, and it's very much a team approach. So if somebody's having a rough day or having a patient whose acuity has increased, you definitely have coworkers who are going to step in and assist you.
And as I was mentioning earlier, patient stability is deceiving sometimes, especially in the transplant population. So you can have one patient and then be waiting for admissions when then all of a sudden your one patient deteriorates, and that's really all you can take care of at that moment is that one patient. So I think the support network that you see on the units is really important, and people are very collegial, and teamwork is really a big theme.
And what is the patient-nurse ratio at City of Hope?
So on our transplant unit, it's usually 1 to 3.
Okay.
On our hematology, it's 1 to 4.
1 to 3 to 4. I think in medical oncology, it's 1 to 4. And then in the ICU,
We're 1 to 2.
1 to
Yeah.
2. What about pediatrics?
I'm not sure.
I believe
thought it's 1 to
pediatrics is 1 to 3.
1 to 3.
And there's a lot of flexibility depending on the acuity of
Right.
the patient. So.
Okay, great, thank you. The next question was asked on Google Plus from Ford. And what would be your ideal candidate for the new grad nurse program? And so I think I can hit on that a bit, is that we are looking, as we talked about, for intellectual curiosity is important, as well as just an ability to come alongside of our patients and their families as they move through the process of dealing with cancer, whether it would be end-of-life care or just helping them, give them that hope that they're going to get through the treatments they're going through that day. So that's mostly what we look for, just that compassion is one of our values. So compassion, service with a sense of urgency, intellectual curiosity, being able to collaborate with your coworkers. Those are real ideal candidates that we're looking for. So I hope we answered that question for you. And we are also looking for nurses that were experienced during nursing school, either in an oncology preceptorship as our preference, as well as an oncology rotation would be a requirement, because as the panelists were talking about, being able to know what an oncology patient is and how to work with the family is crucial for us. And the next question is from Michael. It says, I'm very interested in the future of oncology nursing. How involved are the nurses in the clinical trials and the research at City of Hope? And what types of research happens at City of Hope? So do you want to answer that? There's 3 questions. So he's interested in the future of oncology nursing. And let's do with the first one, how the nurses are involved in the clinical trials and research.
So I think Marie was talking about the Alpha Clinic earlier. That's going to take place where we currently have the day hospital, and it's stem cell therapy for disorders that currently we don't transplant for. So that's one of the new types of developments that's really up and coming and exciting.
I think the nurses are very involved dependent on the type of clinical trial. So we do provide drug clinical trials. So the staff on the nursing staff does administer those medications, as well as helping the clinical research nurses collect information if there are certain criteria or monitoring criteria that need to be met for the protocol, drawing labs that may be required for the clinical trial. There are a lot of survivorship or long-term follow-up studies as well that are trials to watch the trajectory of patients as they move further out from care. It's more of a chronic disease now in oncology versus an acute care. So we really do see our patients and treat them for a lot longer period of time, and addressing issues that may come later post-care or post-transplant, and being available or having the resources available for those patients. So I think there are a variety of ways that nurses can be involved in trials.
I think also that as you gain experience in the world of oncology nursing, you can then up the participation in the clinical trials. There's of course, the research nurses. So those are positions that open up. You have to have a background in oncology, but that's what you learn when you're at the bedside. And then if you continue to progress, then you can up your participation in the trials just by doing something different. So, it's always there. Again, everything's there at your, there. You just have to be able to take care of it and to grab it.
I also think that's another great thing about City of Hope is that there are all these different avenues that you can explore. You can spend your whole life at City of Hope doing different things.
Right.
It's so big.
Yeah.
So I think that really is something that makes us different also than a community hospital.
Right.
Yeah.
A lot of opportunities in different areas.
We've had nurses that have been here for 30 years. And we
A
have a lot of them. Yeah.
You mentioned clinical research nurses. What would we be looking for in a clinical research nurse? What do you feel like ideal? And what
Attention to detail.
attention to detail.
Yeah, again, it's all about the detail and understanding what is the important question? What are we asking here? How are we getting the information? The data gathering, the interactions with the patients, the physicians, everything that goes into, of course, establishing a clinical trial is very important. So you have to multitask, know what's going on with the patient. It's quite a position.
Yes.
And then you have to teach it to the staff nurses.
Right.
Well, once,
Yeah.
very good. I know the manager told me to look for someone that if their kids loaded the dishwasher, they reloaded it.
Yeah. That kind of stuff. Yeah.
That's the kind of nurse we're looking for.
Detail.
Detail. Okay, the next question is from Joseph from Google+. What have been the biggest struggles you've seen new grads have, and what can be done to avoid them? It's a great question.
Some of the struggles that the new grads have is understanding the complexity of the patient population. So I think traditionally, the first few weeks of the residency program, everyone's very excited and they're ready to be a nurse. They're finally done. They have their license. And then about week 6 or 7, I think the realization of a few more weeks and I'm going to be doing this on my own, and how will I ever know the answers to all the questions that are in my head? So I think really realizing that it's a steep learning curve, and after the orientation process, you're not on your own. There are a lot of resources for you. The PPLs are very supportive in helping answer questions and supporting staff who may still have areas where they need some help, as well as charge nurses, assistant nurse managers on the units, and coworkers who have experience and will help support. So the preceptor, as well as working on some a mentorship program that could help support residents after they've completed their residency program.
That and time management.
Time now.
Yeah, and those are things that, we can say it over and over again, and the new nurse can be willing to do whatever it is that we say, but it's something that is developed. Again, it's a period of development that you have to allow yourself. But for me, the thing that I see that our new grads struggle with is the time management of the day, because 12 hours seems like a really long period of time, but everything is time sensitive.
Right.
And if you're juggling 3 patients and time sensitive items, medications, blood products, procedures,
Something
physicians,
changes.
something changes and they're going down, and what am I supposed to do? It's all of that, and that can be a struggle,
Right.
but they can do it. Nobody was perfect in the beginning.
Yeah.
And I think also something that's a recurring theme is the new grads get really hung up on the amount of medications. So especially for our transplant patients, they're on so many types of medications, so many types of IV therapy. If you walk onto the unit and you look at the IV pulls, like other nurses have come onto our floor and say that it looks like Christmas trees.
Right.
So I think new grads initially get very frustrated because not only are you looking at all the different types of medications, but then are they compatible? What line can you run this through? And you can't run it through that line, but you don't have a whole lot of access.
Right.
So then that also ties in with the time management, because if you have all these antibiotics and not enough access, then you have to really manage your time really well. So, and I think that's just something that comes with experience, and every new grad sort of gets overwhelmed,
Right.
but we just make sure to emphasize that it's something that comes with time, and it will happen. It just takes you getting there. We just need to get you there. So.
Sounds great. Okay, the next question this is from Lori, and she says she's been an RN for the past year and currently working as a correctional nurse. I've spent time at City of Hope when my brother was a patient there. Since I have a year under my belt now, would I still apply for the new grad program at City of Hope? I'm very much interested in working in oncology. I guess experience. What I would recommend would not be the new grad program, Lori. It would be more the experienced nurse program is what we'd probably want you to go ahead and apply to that position. Okay, and then the next question is having med-surg experience qualify you for the experienced RN program, and would a non-med-surg nurse qualify as well? And the answer to that would be yes. We are looking for experienced med-surg nurses. We're looking for that nurse that has about 2 years experience. Sometimes between the 1 and 2 is fine to apply to, but for the experience training program, we are looking for a minimum of 1, preferably 2 years experience as an RN, and a med-surg unit would be fine.
Acute care.
In acute care. We are preferring acute care though. And the next question is, how do I apply for the experienced RN program, and when can I apply? I'll let Leilani answer that question when we'll open up that requisition.
Well, the requisition will be opening up in a couple of days, and it's going to be listed as Experienced RN Training Program. And just go ahead and apply online, and this will actually be for the August 2015 start.
I think we're slotted for August the 23rd or 24th is around the time they'll start, that Monday in August. You guys were mentioning earlier about the Biller Resource Center for families and patients. Can you talk a little bit about that? When we were kind of talking offline, we talked about the Biller Resource Center. Can you tell us a little bit what goes on at the Biller Resource Center and what's available to our patients and families at the Biller Resource Center?
It's an area of the hospital that it's actually like a, what do I want to say, an office space. It's almost like a small library.
Mhm.
Yeah. And they have computers set up and reading materials. And then, of course, there's people that actually work out of the Biller Center. It's the clearinghouse for all supportive services that we offer to our patients and patients' families. So they can go in there and use the computers. They can go in there and get all kinds of information. The Biller Center sets up all these different types of programs, both anything from yoga to dietary classes to
Support groups.
I mean, it's just a clearinghouse of all the wonderful services that the City of Hope offers as far as the support of not only the patient and their experience, but the family experience or the loved one's experience, or whatever you want to call your significant other. It is there for you. And it's really important that we have that, because we're not just treating the individual, we're treating their whole support group.
We also have a very large variety of print resource material. So it's a very good resource-rich area where people can go for printed material both in English and Spanish.
Probably, I don't know.
We have a question from Imelda. She said, I did the entry-level Master's of Science in Nursing, so I have a BSN equivalent. I heard from other sources that City of Hope doesn't hire RNs who went through this program to get their RN. I just need clarification because I'm interested in working with oncology patients. Imelda, to answer that question, we would require that you had finished the MSN. Once you finish the MSN, we're very much interested in you. You have to actually have the degree. We do ask for you to have the actual diploma. So the Master's of Science in Nursing would be perfectly fine. So once you complete that, we'd be very interested in speaking with you. It doesn't sound like you have RN experience, so you would apply to the new grad program once you have the diploma in Master's of Science in Nursing. So I hope I answered that question for you, Imelda. Okay. Another question?
I don't have anything.
Okay. What are the things that brought the three of you to City of Hope?
Wow.
And how long ago?
Yes, if you could share how long you've been at City of Hope and what brought you. We'll start with Marie.
Okay, so I've been here for 15 years. I was trained out at Loma Linda, which is east of here. And then I came back west because I live in a city close to City of Hope. And actually what brought me here was that they opened up the first ICU hiring at the City of Hope. I think they hadn't hired a new person in their ICU for like, I don't know, I want to say ever, 15 years or something. And I was, myself and another nurse were the first two new hires into the City of Hope ICU for forever. And I remember telling the person who hired me, who was Norge, Marge Northrup. I told her, I think I found my home. And I knew that when I drove in. It's not just how beautiful the gowns are, the serenity that you feel when you first drive in, but it was also the way I was interviewed and the patient population. I was very fortunate to get hired, and I've been here ever since. So yeah, it's been 15 years.
How about you, Jennifer? What brought you to City of Hope, and how long have you been here?
So I've been at City of Hope for 12 years, and working as a travel nurse brought me to City of Hope. So I initially came as a travel nurse and had worked in other bone marrow transplant units around the country and loved working with bone marrow transplant patients. So it seemed like a good fit for a travel contract. And when I arrived, I thought, wow, this is such an easy transition. The patient care is very easy to learn for me. The people were very supportive, the unit and the nurses on the unit. So my travel career ended very quickly, and I stayed at City of Hope in Southern California.
The rest is history. How about you, Kay?
So I started here at City of Hope in 2006 as an ambulatory care assistant in the outpatient setting. And I did that for about a year. So I would flow inpatient as well as outpatient as PCA / ACA. And then I got hired onto the VMT unit in 2007. And I did that for about 4.5 years. And then I went outpatient.
As a new
also,
grad.
yes,
As a new RN.
I
As a
came
new
in
grad
as a
RN.
new RN, yes. And then I went outpatient, and I did that for about 2.5 years. But that was also in the bone marrow transplant area.
Okay.
So it was really nice because I got to see the other side of transplant. And then about, I want to say almost a year ago, I became an educator. So
Wow, that's great. I know when I'm touring people, they comment on how serene City of Hope is and how quiet it is. And part of it is we don't have the overhead paging system. I
Right.
noticed, Marie, you have your Voicera. Can you just share with our viewers, what is Voicera? What is that all about?
Well, it's a hands-free, I want to say walkie-talkie. I'm not sure that's the right
Communication
Communication device. But it's hands-free. They have a little button, you push on it, and it actually recognizes, it's a voice recognition, and it recognizes as you call for someone else. And then if I was to call for Kay, I would push this, and then it says, call Chemo, and then it would actually be transmitted to Kay, and Kay would hear my voice. And so yeah, it's an interesting, the doctors use it, some of them use it, I should say. It's used in the operating room. It's used almost I think just about everywhere in the hospital, isn't it?
And our
Yeah.
codes are called through that. Is that correct? Or
The codes are called, well, they have been doing a little bit of overhead paging,
Okay.
and then we actually have what we call the code pagers. And then the rest of us get notification of page via our pagers also.
A lot of people, when I tour them, they say that City of Hope looks like a national park.
Mhm.
Yeah, it
And
really
the
does.
grounds are beautiful.
The grounds are beautiful. The
Right.
rose garden. How many acres do we have? I think we have
I don't know, geez.
10 acres. It's just
I
a
don't know.
beautiful, beautiful, serene place. That's the thing that impresses everybody when we give them the tour.
Yeah.
animals.
Yes.
It's really nice. They actually have a designated pathway because we have a lot of emphasis on keeping yourself healthy, not just the nurses, but all the other staff members that work throughout the facility. And there was actually a designated mile pathway, and they do a lot of, you'll see people walking, during breaks or
Right.
before they go into work or after they go into work. We actually have a group of nurses in the ICU that we're training for half marathons together, and they would actually run the City of Hope a couple of times as it starts to get dusk. So it's actually, there's a lot of really interesting things that go on that actually encourage you to take care of yourself, because we can best take care of our patients if we ourselves are healthy and intact in all aspects of our life. So yeah, it's really nice.
There's another aspect that when I'm giving a tour, people are very impressed with our Hope Village and our Parson Village that we have for the family members and the patients. Can you guys share about Hope Village and Parson Village and about how the patients can stay there with their families while they're going through treatment?
So bone marrow transplant patients, after discharge, they have to come back for follow-up pretty frequently, a couple times a week. And so if you live in excess of a certain number of miles, then you qualify to live temporarily in Hope or Parsons Village. And so it's just a convenient way for patients to be local, and if they are in need of assistance or if there's an emergency in the middle of the night, they're close to the facility,
Right.
and they can make it to their appointments so frequently.
Right.
So that's something that we offer for our bone marrow transplant patients.
And other patients who need frequent visits to the clinic, or the distance of the geography is prohibitive. So there's small individual apartments with little kitchenettes that the patient and the family member can live in, with the convenience of being very close to City of Hope.
I think that's great. That was something that really impressed me when I came here, was keeping that continuity with the family, that they're not apart during the treatment. Anything that Teresa or Leilani would like to share, or any tweets that have come through that you can, questions that
You're doing an amazing job. All of you, want to thank you all for participating, and all that have joined us live. This is very exciting, and we're going to continue this. Just really looking for some really strong, again, compassionate and just caring nurses that can be able to bring this to our patients.
Well, City of Hope is a great place to work. You do get a lot of support here. Obviously our professional practice leaders provide you as much support, and they're here to take care of you, and we're all in this together. So I usually say City of Hope is like family. And when I came here to interview again, my interviewing process was very positive, to the point that, I've been here close to 4 years, and really happy about that. And we are excited about recruiting nurses that are compassionate and have the passion for oncology, bone marrow transplant, and hematology. And so if you're an experienced nurse and you're looking into the training program, we'll be posting those positions posting that position in a couple of days. And if you're a new grad that's interested in coming to City of Hope and oncology, then you could also apply for the August 2015 program.
That's great. We do have a couple more questions that just came through. How long will the training be provided for the experienced nurses, and how long will the class and clinical training, how long is it? How many weeks is the experienced RN training program? You mentioned that it's
14.
16 weeks. You've got 16 weeks for a new grad. How about for an experienced nurse? How long?
So we tailor that per individual and how they are acclimating to the patient population and the clinical needs. It's minimally 10 weeks with the classroom didactic portion, and then we evaluate at the end of that how they're doing, because that is included with 2 clinical shifts with a preceptor on the unit that you're assigned to or have been hired for. So it's minimally 10 weeks, and then there's some flexibility beyond 10 weeks depending on how the person feels in their progression.
And for the experienced RN, again, it depends on the RN themselves. I know that when we hire the experienced RN without any oncology experience into the ICU, we send them through the different units to learn the patient population there. And I think I already spoke to this. And then they're precepted once they get into the ICU for X number of shifts, and then we follow up with them on a weekly basis to see where they feel they are. So it's not just the preceptor giving their overview of where the nurse is. The nurse actually has to talk to us and tell us, yes, I'm comfortable, or boy, I'd really like to have a little bit more experience. So there's really not a hard
number of weeks.
Yeah, hard number of weeks. It really, some nurses are ready to fly right away, and others, need to be a little bit more sheltered for a while, and then off they go. So it's a personalized experience.
I noticed this last year we started an ICU training program that we were experienced nurses. We were training them. How long does the ICU training program typically last?
Again, that it's like anywhere from 4 to 6 weeks out on the different units. And then we try to have them have at least anywhere from about 10 weeks. 10 weeks,
10 weeks with ICU training program.
Yeah, they have to be able to say, yes, I can do this, because it even coming from some of our other areas, it can be a little overwhelming to see the the patient population that we deal with, so.
Great. It looks like there is another question. Since I've been a nurse for 20 years but never had experience with oncology, what are the precautions that nurses need to follow, especially in giving chemo drugs? That's a great question, and that's from So how would you guys answer that question about the precautions that need to be taken in administering chemo drugs?
So I don't think that there are special precautions, there are just precautions. And we, like I mentioned before, we put you through a chemotherapy, biotherapy course. And I think as long as you stick to what is safe and what has been recommended, I think it's a very safe practice.
Yeah, it's dictated by, of course, not just the organization. So it's not just City of Hope, it's also all the other regulatory agencies, the state agencies, federal agencies that play into the handling and disposal of these drugs. So we have policies that actually dictate how these drugs are to be handled. So it is, but nobody's watching you do it. So if you're giving chemotherapy or you're hanging chemotherapy at 9 o'clock and you choose not to be safe, well, you can choose not to be safe. But there are actually ways, and they're very, very, again, we have a safety department that's involved with this. There are very prescribed ways of delivering certain drugs. And all the personal protective equipment is always advised is there for you to grab. There's also dictated methods if there's an accidental spill. So we're very, very safe. We're very aware of not only the importance of delivering the medications safely to the patient, but also the safety of the provider. The safety of the nurse giving the medications is always very, very important.
We had not mentioned previously that we do have a cancer center out in Antelope Valley, and we have several other cancer centers. We have one in South Pasadena. We have offices in Rancho Cucamonga, Corona. So we are expanding the oncology nursing in those areas for those of you that live outside of the general Los Angeles area where the ward is next to Pasadena. The next question that came in was, do you need to have telemetry experience to do better in oncology nursing? That's Sonia asking that question. What's your thoughts about telemetry?
Telemetry is an important part of any monitoring of the patient. I think as we move forward with plans for expanding our telemetry unit, I don't know when that will happen, but it will eventually happen. The cardiotoxic effects of the medications that we give really are need to be monitored. And I think in order to provide best patient care and safe patient care, we will be expanding that. Right now we have it on 2 floors. I think we have a capability on the telemetry beds. I know all of 4 West, so that's 18 beds. And I want to say all of 4 East, but I'm not sure. But we have the capability of handling a number of our telemetry patients.
Outside the ICU.
Outside the
Outside.
ICU.
Okay, great. That's great. Okay. Don't see any other questions. I think that's going to wrap it up, and we hope that you can join us next month when we have our next tweet chat that we will be hosting on April the 21st at 3 o'clock. And thank you again. And there goes our voice, Sarah. Thank you again for joining us.
Thank you.